Welcome back, everyone, to the last part of Where's My Money educational series. We are going to end this event with maintaining compliance with medical charting, billing, and coding update for 2022 with Dr. Katie Connolly. My name is Dr. Stephanie Wu, and I am the host for today and the founder of Wu University. And it's now my pleasure to introduce Dr. Katie Connolly. Dr. Connolly is an associate clinical professor and the chief of the Pediatric and Binocular Vision Services at Indiana University School of Optometry. She serves as the director of the Myopia Management Clinic, as well as the coordinator of the Pediatric Optometry Residency Program. She teaches in the clinic, the laboratory, and the classroom, including teaching a course to third-year optometry students on optometric coding and billing. She leads several vision screening and eye exam initiatives at the local, state, and international level. Her special interests include amblyopia, strabismus, vision screening, myopia management, and all-inclusive health. So Dr. Connolly, it's a pleasure to have you today. Thank you so much for joining us. We cannot wait to learn from you.
Thank you very much, and thank you for the introduction. And kudos to all of you. If any of you have been on all day to sit through 6 hours of coding lectures, that's quite the feat. So I give you some props if you've been here all day. Hopefully there's not a ton of overlap between myself and the other presenters. I didn't listen to the other presentations, but I know we had some similar topics. But I do feel pretty strongly that coding is one of those subjects where you really do well learning by repetition. So hopefully if there is some repetition, hopefully I can still give you a couple little nuggets here and there and make this last 2 hours of your day worthwhile. I don't have any financial disclosures, so we'll go ahead and dive right into the meat of it. So really the core of my conversation today is to talk about CPT. I'm really not going to talk much about ICD-10 coding. I left that to some of the other presenters. So we're going to talk really about deciding on our fee schedule and deciding on our procedure code. And as we all know, right, CPT is a medical code set that's used to report medical, surgical, and diagnostic procedures and services. And we attach that with an ICD-10 code to our insurance carrier for payment. We, as the doctors, we're responsible for setting the fees, but unfortunately, we don't determine our own reimbursement rates, and those are determined by the insurance carrier, or if they're cash pay, of course, they're going to pay what we set for our fees. And the definitions of the codes that really we're going to talk about today are all a registered trademark of the American Medical Association. So the AMA defines the codes, we set the fees, and the insurance companies pay us what the contracted rates are through their reimbursement schedule. There's several categories of CPT. So there's 3 separate categories. Category 1 is really what the heart of it is for us. Category 1 includes evaluation and management coding, as well as the medicine section, which is where the vast majority of all of our codes come from. We do have a few, of course, in the surgical and radiological codes that we deal with, but a much lesser volume compared to E&M codes as well as medicine codes. There's also the clinical laboratory services, which for those of you that see a high enough volume of Medicare patients or bill enough to Medicare, it's used to track the quality assurance through MIPS and through MACRA. And then category 3 is used for emerging technology, services, and procedure codes. Those are often temporary codes or ones that are used in research. So we will not touch on those today at all. Really, our conversation is going to be centered around category 1 and looking at E&M codes as well as codes in the medicine section. For us in category 1, this is really the list of our most common codes. We deal with on a day-to-day basis the general ophthalmological exam codes, E&M codes, all of our special tests, and then maybe not every day, but most days deal with surgical codes and contact lens fittings, as well as those glaucoma screening codes. And then for any of you that still have S codes on your fee schedule, those really are not utilized anymore. They create compliance issues with routine vision plans. While they were nice because it was easy to separate fees for a routine eye exam compared to a medical 92,000 code, we really aren't using those anymore in our repertoire. Our most common codes, the ones that we're going to focus on today, are the 92,000 codes as well as the E&M codes. And as we all realize that there are new and established versions, new meaning that there's a 0 in there, and 1 meaning that an established meaning that there's a 1, but there's no difference between new and established for the procedure codes, the surgical codes, or the contact lens fit codes. The 92,000 codes create a lot of confusion because there's really two ways that we think about those 92,000 codes, and that's through vision or medical. And I think a lot of doctors miss out on money if they don't really understand the difference between how to handle these for vision and how to handle these for medical. We're going to spend more time talking about medical, of course, but I just want to dive into the vision piece of it a little bit just to put ourselves in the context of understanding what the medical definition is for these general ophthalmological eye exam codes, or also known as the medical eye codes. So we all know, right, when we sign a contract with a vision plan, they're going to send us what their requirements are, what we have to do for exam elements in order to get paid. And this is what IMED's list is. These are the things that we have to do. I pointed out because it kind of makes me giggle that IMED used the wrong affect effect here, but this is what we have to do, right? We have to take a complaint, do a history. We have to ask about family medical history. We have to do the few things that they require for us on the exam list or in our examination, which are all listed here. And then we carry through and we code our comprehensive eye code. Other little things to think about with IMED that is going to pop up in some of these other vision plans is that they all have their own little nuances. And you really need to read the contracts for all the different ones that you're signing so that you know what you have to do in case you go through an audit with these plans. For example, for IMED, you have to offer dilation or do dilation if the patient is diabetic. The eye exam will include a dilation within 30 days of their initial eye exam. So it can get a little bit hairy if you have that diabetic patient comes in and you want to use their medical plan because it's going to pay you more money if you use their medical plan. So a good way to kind of skirt around that is to think about always doing the medical eye exam first. You can train your staff that when the patient calls to book an exam, all new patients are asked the question if they're diabetic. If they are, then tell them that your policy is to schedule the patient first for their diabetic eye exam. They'll be dilated. You don't necessarily have to do a refraction at that visit. And then you're going to bill their medical exam and then have them come back to complete the glasses portion. I know that doesn't work well in every practice, but it certainly can work well in some. And I know a lot of practices that use this philosophy and it works quite well for them. And patients do tend to come back for it because you haven't released their glasses prescription. So it's a good way to stay in compliance with IMED because you don't need to offer a dilation to the patient if they've had one done within the last 30 days. And it's a good way to pick up revenue from both billing the medical plan as well as billing the vision plan. So I think we all have a good idea of what we need to do with vision plans. We deal with those every day, all day, it seems like. But now let's transition into talking about these medical eye codes. So medical eye codes, there's two flavors. There's the comprehensive and the intermediate. And this is the definition that comes from CPT on what a comprehensive eye code is. But really what it means is that it's a complete evaluation of a medical problem. We use these really commonly for yearly exams. So people that are coming in for their yearly macular degeneration exam, yearly cataract exam, maybe yearly exam in which they have dry eye, anything like that. And now in today's era, in 2021 and beyond, really these are ideal for medical visits in which we only observe. And I'll hit that a little bit further as we move into E&M coding, but you'll see as to why these medical eye codes really work nicely in which your plan is to observe. So example would be a posterior vitreous detachment where you don't have to do, you're not referring, you're not doing any active treatment, you're really just watching and making sure that nothing bad happens. These codes now work really well for those compared to an E&M code. And remember that these are reimbursed really well through Medicare. For a new patient, right now it reimburses $142, and for an established patient, $119. So much higher, of course, than our routine vision plans, and in some cases can certainly beat out an E&M code, which is why we can't forget about the usefulness of these codes. So this whole paragraph here, I think it's nice if we think about it in table form as to really what we have to meet. So these are the requirements for a comprehensive eye code. So it's required, of course, that we take a medical complaint and do a history. And then you also have to do a general medical exam. What that means is that you have to somewhere in your record comment on the patient's overall systemic health or their general constitution. If it's relevant, it can be about something to do with their systemic health related to their complaint. A good example would be if the patient had a recent sinus infection, you could write that down. If the patient has diabetes, talk about the fact as to whether or not the diabetes is controlled or not well controlled. There's not a lot of detailed instruction here as to what we have to do, but some comment on the patient's overall medical status and their systemic health. And then exam elements that we have to do are relatively limited. You only need to do a gross visual field, a basic sensory motor, which is either EOMs or a cover test. It does not need to be both. And then you have to do a posterior segment exam. And for most insurance carriers, dilation is not required, though do check with your carrier. Some do require dilation, and sometimes it depends on what area of the country you're in. And then you also have to do a treatment initiation. And that's probably the hardest piece to hit. So I think when you're contemplating using these comprehensive eye codes, stop and ask yourself, did you do a gross visual field, an EOM, and did you look at the posterior segment? If you did, you've likely hit everything in this category, minus potentially this last column. Because by nature, we do a medical chief complaint, right, and a history. Doing the general medical exam might take a little bit more work for us to remember to write those things down in our chart. But likely, if you've done all of these three elements here, you've probably hit the comprehensive eye code. Now, the last piece of it is going to be this treatment initiation, and that's what can be somewhat challenging. So this is the official definition of treatment as defined by CPT. It means the prescription of medications, arranging for special diagnostic or treatment services, consultations, lab procedures, radiological services, and refractions. So it's not necessarily what you and I would always think of as treatment. This is what the definition is of treatment is in order to meet this code. So some good examples: prescription medications, over-the-counter medications or recommendations, all of those count as treatment because those are all the prescription of medications. And then the other would be arranging of any special diagnostic or treatment services. So we do a lot of these in our practice. We order tests in the medicine section of CPT 90,000 all the time. Examples include, of course, gonio, visual field, OCT, refraction. You do sensory motor tests, those all count. If you refer the patient to another healthcare provider because you're coordinating care and you're providing a consultation, that also counts. If you order any clinical lab tests or order radiological imaging, such as an MRI or a CT for a visit, that would also count. And then the one that's really helpful for us is that if you prescribe glasses or do a refraction for a medical purpose, this also can count. So think about the patient that's coming in with cataracts or the patient that's diabetic. Of course, it's really important to do a refraction on those patients because the information you gain from doing that refraction is going to help you in determining the treatment outcome for those patients. Also, in anyone that has ocular disease, it's always important to determine what their best acuity is. That's really where your logic for doing the refraction comes from in patients that have medical diagnoses that you're using these comprehensive eye codes for. Things that are not considered treatment are just basic follow-up. So if you just have return to clinic in 6 months for monitoring, that is not good enough. Another that is not good enough is just standard communication. So things that are just considered automatics, like sending a diabetic letter to report the status of the eye exam, is not considered treatment as defined by CPT. It needs to be more substantial for that. So where auditors are looking for in your chart to figure out if you've met treatment as defined by CPT is they're looking in your plan and they're looking in your interpretation report. And this is probably the number one reason why providers fail audits on the comprehensive eye code is that they have not met treatment as defined by CPT. So do watch closely for this in your chart and make sure that you're documenting if you did order a special test or if you did a refraction, because those are the things that are going to carry you to the next level. So let's look at a patient case. So here we have an established 65-year-old patient who's complaining or coming in for a cataract exam, and they do have the complaint of blurry vision. And that blurry vision is all the time. It's been getting harder to drive at night. The patient is healthy, and we make that comment in our chart, and we've reviewed their medications and allergies, so we certainly have the general medical exam covered. Examination-wise, we do visual acuities, pupils, EOMs, and confrontations. We do a cover test and a refraction, a brightness acuity test, as well as an IOP. And then we do a full ocular health exam through anterior segment, as well as a dilated fundus exam. So we've certainly hit all of those checkbox exam elements because we've done the EOMs, we've done a gross visual field, and we've done the basic sensory motor. So we've really hit all that we needed to, and we've done that dilated fundus exam as well. So the patient's diagnosis here is that they have cataracts and then refractive error. The cataracts are worsening, so we prescribe glasses to improve their acuity. They don't need to have surgery, and they can come back again in a year. So we've really hit all of our check boxes. And this is an exam that many of us see on a daily basis, if not multiple times a day. This is a very standard exam in our optometric practices. And we are easily hitting these comprehensive eye codes because we're going to be hitting all of these elements quite simply with a routine eye exam. And then that treatment initiation on your cataract patient is going to come from doing the refraction and prescribing glasses. So now let's look at the intermediate eye code. I think this is the one that people have more confusion with compared to the comprehensive eye code. And that's because there's some language in the definition of this code that really becomes somewhat complicated. So this code describes an evaluation of a new or existing condition that's complicated with a new diagnostic or management problem, not necessarily relating to the primary diagnosis. And that's the complicated statement. The rest of it is pretty straightforward. It includes a history, again, that general medical observation, external ocular and adnexal exam, and other diagnostic testing procedures as indicated. And it might include the use of mydriasis, but it's not required. These are, of course, going to be inherently problem-focused visits. So these are not your patients coming in for their yearly cataract exam or their yearly diabetic exam. These are best suited for people coming in with problem-focused issues. So here again, if we put it in table form, it makes it easier. So you need that medical complaint, a history, a general medical exam. You do need to do an external exam, but otherwise that's really your only requirement when you're dealing with this one in the exam in terms of the elements that you have to perform. But this is the challenge right here, that evaluation of a new or existing condition complicated with a new diagnostic or management problem, not necessarily relating to the primary diagnosis. So what in the world does that mean? I think we can break that down into really 4 ways that we can use this. Number one, and the easiest one by far, is a new medical diagnosis that requires a new management plan. That's your slam dunk one, because it says right here, right, evaluation of new condition with new diagnostic management problem. So this is, any red eye that walks in your door that requires a treatment of any kind, because you've got a new problem with a new treatment. The second way we can do that is if you've got an established problem now that has a new treatment option. So you've got an existing condition with a new diagnostic or management problem. So a patient comes in that has dry eye, it's worsening, so you're adding more treatment. You're adding tears, maybe you're adding warm compresses, or you're adding a prescription medication. Another example is glaucoma that is progressing. So you're increasing medications, or you're adding medications, or you're changing something about their medication. The third way that we can use this is through a new diagnostic management problem for a secondary diagnosis that doesn't necessarily relate to the first diagnosis. So an example here is patient comes in, they have macular degeneration, and that's why they're primarily there, but they also come in with a secondary complaint of eye irritation. And you find what that diagnosis is, why that eye irritation is occurring, and then you also have a new management problem or a new management plan for them as well. So this is another way in which we can use it. Another one is a change in treatment for an established medical diagnosis. So this is the one that kind of throws people off sometimes too. It's any change in treatment. So it's not just when something's worsening or when you need to increase medication. It can also be when you're decreasing medication. So patient has an iritis, for example, it's getting better. So you make the clinical decision that it's time to start the steroid taper. And you're getting credit for the fact that you're going through the thought process and you're making that judgment call as to now is the time to do that. It's not just going to be a status quo and continue on. So you can also use this code in those scenarios. Really, the time that you can't use this is when you have a stable diagnosis that you don't have a new plan for. So best example, and probably the example that's going to come up the most often, is going to be stable glaucoma. IOP is where you want it to be, and you keep them on the exact same drug and dosage, and you bring them back for a follow-up in 6 months or whatever your protocol is. So those are the scenarios in which you can't use this 92000 code. So let's go through some examples. So here's our easy one first. So we've got a patient that comes in and is complaining of red eye. It's been going on for about a week. It comes and goes. It's associated with itching and sneezing. We go ahead and do the relevant past family medical history, allergies, medications, and review of systems. The patient has recent cold-like symptoms, but everything else in their history is not pertinent to this particular visit. Examination-wise, we do visual acuities, pupils, IOP, and anterior seg. Remember, the only exam element really that you need to do with these 92,000 codes is an external and a nexal exam. So you don't need to do a posterior seg exam. You don't need to do the EOMs or the confrontations. Of course, do them if it's relevant for why the patient's coming in, but it's not a requirement of the code. So this patient here has a diagnosis of allergic conjunctivitis. It's new and it's moderate severity. We go ahead and start them on Pataday and tell them to come back just as they were already scheduled for their full exam. So have we met this code? So we certainly have a medical complaint. We've got relevant history surrounding it. We have the general medical exam done. We did, of course, look at the anterior segment. And then we do have a new problem that's complicated by a new management plan. So we've absolutely hit this 92012 code. Now let's look at another example. Here we have a 45-year-old patient, and this one's coming in because they have dry eye and they're here for an established patient follow-up. It's long-standing. The patient's been using a Bruder mask twice a week, and twice weekly, and they've been using Restasis twice a day. But they have this new complaint now of an eyelid bump that is tender to touch, and that just started a few days ago. Very similar examination sequence as previous. We do acuities, pupils, IOP, and an anterior segment. And this patient here still has their dry eye. It's bilateral and it's stable, but they have this new diagnosis now. So they have a new hordeolum in their right upper eyelid. Their plan is remaining the same for their primary diagnosis, but this secondary diagnosis now, we need to add a treatment for that. So they're going to increase their Bruder mask to twice a day until symptoms resolve, and then they'll go back to using it ideally once daily instead of twice weekly. So here we go. We've hit all of our exam elements just as we did before. And now we've got the same, we've met this criteria down here. How we're meeting it is that we have a new problem that's complicated by a new diagnostic or management problem that is not necessarily related to the primary diagnosis. I think we could all argue that, dry eye and hordeolums, of course, come together quite often, but it's not just purely dry eye, right? This is a separate diagnosis. It has a separate ICD-10 code. So this is not considered to be the primary diagnosis. Now let's look at another case. Here we have an established 65-year-old patient who's coming in complaining of macular degeneration, and they're here for their standard follow-up. They say that their vision is stable, and it has been for the last 6 months. They're using their Amsler grid once a week like they're supposed to, and taking their AREDS vitamins twice a day. We do a relevant systemic history, and then exam elements here are a little bit more extensive. We do VAs, pupils, anterior seg, posterior seg, and an OCT. And then so I'm going to stop and say right here, right, by looking at my exam elements, I know that I cannot meet a 92014 because I haven't done a basic sensory motor exam and I haven't done a confrontation or some sort of screening visual field. Could I have justified those exam elements on someone for macular degeneration? Probably, but regardless, they're not in my chart, so I do not meet the criteria for that code. So I'm going to be stuck down at a 92012, presuming that I've met the other requirements for this code. So here we've got stable macular degeneration. We decide to continue with the Amsler grid and continue with the AREDS vitamins and have them come back in 6 months. So now have we met it, right? We've met all of the requirements of the code up until this statement. And we unfortunately have not met the statement here for this particular visit, because they don't have a new problem and they don't have a new management plan. This is the example of stable and keep going as you were. So unfortunately, this one does not meet the 92012, and you would need to bill an EM code for it. So why do we talk about this, right? Why do we worry ourselves with having to think about 2 different methods of coding? Because it certainly can make it more complicated for us. We are unique in eye care in that we have 2 sets of codes. Not every specialty has that. Of course, our life has to be almost 3 times as difficult as other specialties because we use E&M codes, we use 92 codes, but then we also use vision coding. So we always have 3 ways that we can bill a patient's visit every time that they come in. But the reason why we want to think about all 3 methods is because of reimbursement rate, right? And so if you look at the reimbursements here, of course, it might be different based on where you are in the country. This is for here in Indiana, and these are 2021 reimbursement rates because I don't have access to our Anthem reimbursements yet here for 2022. But you'll notice that Anthem, at least in Indiana, has really lowered the reimbursement on the 92,000 codes. And they've done that because they're kind of married to IMED here. And so they've taken on the reimbursement rate that's typically given for IMED and for a routine vision plan. So therefore, they really don't pay well for the 92,000 codes. But you can tell that Medicare pays much better, right? So the bottom line here is that an intermediate code is always going to be better than a level 2. So if you're always stuck between a level 2 and an intermediate code, certainly your better bet is an intermediate code. But there might be scenarios where the intermediate code is better for you, depending on what your other carriers are paying you for E&M codes. And then a comprehensive code is pretty much always going to be better than a level 3. If you're billing a level 4, then you might want to, again, look at your reimbursement rates and think about choosing the level 4. But if you're between a level 3 and a comprehensive code, you're likely going to be better off billing the comprehensive code, which is going to become important here as we transition ourselves into looking at evaluation and management codes, because the way that we code now for E&M is so much different than it was before. And it's different in the sense that our observation that we're doing with patients does not count for risk the way that it used to. So when we're just observing an exam, we really don't get to bill very high for an E&M level. So using these intermediate and comprehensive codes might pay us better and might be the better ones to use just in terms of the definition of what we're doing. So let's go ahead and transition into E&M coding. So as we all know, right, our previous format was based on 3 key components, which was history, exam, and medical decision-making risk. And that medical decision-making risk was based on problem points, data to be reviewed, and table of risk. And new patients and existing patients were coded differently depending on which key elements you hit. It was harder to bill a high level on a new patient because you had to hit all 3 key components, whereas in the existing patient, you could throw out the lowest one. And that format really has completely been blown up. I'm sure that we're all more familiar than we were with it a year ago today. But regardless, there's still, I think, a lot that we can learn about how to utilize this coding system to our benefit. So now starting in 2021 and still bleeding over into 2022 is that we are making our decisions off of one of 2 things, and that's either time or medical decision making. And there was some specific goals as to why this process was changed. Number 1, that was to reduce documentation burden on providers. I'm not sure if you guys have felt it. I certainly have. I really do feel like removing the burden from the history component has made a big difference, as well as somewhat the examination component. Not worrying about trying to hit specific exam elements has really been nice over the last year, and just being able to go into a room and ask the questions I want and do the testing that I want. So I do feel like it has reduced the burden on documentation and somewhat the burden on testing. And then, of course, another goal was to simplify audits. And then they wanted coding to be centered more on decision-making and more related to the care of the patient versus checking boxes. And I think that goal was accomplished. There's always flaws, of course, in every system. But in general, I think this one really has been a positive system or positive change for us as providers. And the system that we're using now was suggested by the AMA as an alternative to the CMS proposed system. And in the CMS proposed system, they were looking at just 2 levels of E&M, whereas now we still have 3 levels of 4 levels of E&M that we're using rather than the 5 that we previously did. So let's first look at billing on time. So prior to 2021, you could only use time if the provider spent at least half of the time in the room counseling or doing care coordination. That limitation was removed in 2021, and now time is considered total time that you spend caring for the patient on the day of the exam, including any time that you spend outside of face-to-face time. And time is relatively inclusive, so it's any time that you spend caring for the patient on the date of service. And that's probably the most important thing to remember, is that preparing to see the patient and doing charting and doing care coordination all counts, but it has to be done on the date of service. Looking at the chart the day before does not count. And then, of course, everything that you do in the exam room, all the time that you spend trying to do referrals, any communication that you spend, whether that be email, faxing, phone, letter writing, anything with an outside health professional also counts. Of course, also your time charting. Another thing to remember is that it's only the provider time. So for me, working with students, I cannot count intern time. Otherwise, I'd be billing a level 5 every single time. But for you guys, you can't count your staff members' time. It's just the provider time only. And you need to be able to track and document that time clearly and easily. You need to be able to survive an audit in about 10 or 15-minute intervals, because that's how the coding or how the E&M levels are built upon. And again, you can only count work that you do on the day of service. And I'm sure there's many ways that we can think of as to how this system can be useful. I personally see it as being most useful in people that do a lot of neurorehabilitation or concussion and stroke evaluations, as well as people that are doing low vision services. Those that are doing a lot of glaucoma care or fast-paced retinal care are probably not going to find as much use to billing on time. But those that are doing exams that require really a lot of time on dealing with documentation and a lot of time on dealing with the patient in the exam room will certainly find this to be more beneficial than using an E&M for certain scenarios. So the new patient guidelines and the established patient guidelines for time are slightly different. So this is one place in the new E&M coding where there is a difference between new patient and established patients. And then, of course, as I mentioned, you got about 10 to 15 minute or so intervals between the 4 levels. So that's why you need to survive an audit based on that, and make sure that your chart is clearly documenting how much time you spent with the patient and what you were doing while you were working with the patient or looking at their medical record. And then now for the vast majority of exams that we do since 2021, it's going to be all based on medical decision making. That's now the key factor to E&M coding. So changes to the medical decision making wording. So in the past, it was number of diagnoses or management options, and now it's number and complexity of problems addressed. In the past, it was a matter of complexity of data to be reviewed, and now it's data to be reviewed and analyzed. And then this third category, risk, has really changed substantially. It was risk of complications and or morbidity or mortality, and that is defined now specifically to patient management. But the way we think about medical decision making has really been tipped over on its head. It's a lot different than the way that it used to be. We now think about it in 3 different categories, which is problem, data, and risk. For both new and established patients, you're going to choose the highest 2 out of 3 components. So essentially, you're choosing the middle one. And so in optometry, what you'll see is that most of your billing decisions are being based upon problem and risk, because it's really difficult for us in eye care to meet data. And I think what you'll notice with data, and the more time I've spent really looking through this system, is that you can really tell that the whole E&M system was built for medicine, right? Which makes sense. We're a small piece of this whole healthcare puzzle, but it was built a lot for doctors like primary care doctors. And, eye care is unique because we run a lot of our own special testing. And if you think about other healthcare specialties that we work with or that you've, become in contact with, even as a patient, that's really not the way it works, right? You go and see your doctor, they decide what tests they want to order them, and you go get them done elsewhere. It's rare that the doctor that you're seeing is the one that owns the test and runs the test themselves. Whereas in eye care, that's really the way it is. And that's why our overhead is so darn high, is because we have to purchase all of our own testing and we're running all of our own testing. And it's not that way in the rest of medicine. So it's part of why this data category really doesn't work as nicely for us as it does for other providers within the medical community. I'm sure all of you have probably in your exam rooms, or at least pretty easily accessible, the AMA coding chart. And so we're going to spend some significant time here going through really the AMA coding guidelines in detail, because it's important that we all understand exactly what we're shooting for, so that we're not just picking what feels right when we're in the exam room. And what I asked Dr. Wu to do and her team was share with you guys a copy of the AMA coding card, then also share with you a copy of this card that I put together here. And this is really the AMA coding card, but I've also taken some contributions from some other coding experts, as well as the folks here at Indiana University, to kind of put this into a more streamlined and easy to follow version that we keep in our exam room. So you might find it useful as well, which is why I've provided it to you. Do remember that when you're making your coding decisions and you're going through audits, what the AMA says is what matters. So if there's something on here that you don't feel comfortable with, or something that you think contradicts the AMA, by all means, utilize the AMA, because they are ultimately the people that define what we need to follow for these codes. So for our new category here, when we're thinking about medical decision making, it's going to be in 4 levels. We're thinking level 2 now through level 5, right? We've gotten rid of level 1, And it's selecting based on 2 out of 3 categories. And I know we probably all understand this really well, but I always hit it because I think it just messes a few people up sometimes, trying to figure out what does it mean by highest 2 out of 3. And so here's an example. So we've got if the problem is low, if data is minimal, and risk is moderate, what it means is that you're going to throw away the lowest and you're picking the second highest. So in this case, the final level is going to be the one that correlates to the second highest, the highest 2 out of 3, which would be a level 3. So just want to make sure that we're all on the same page with how we're calculating that. And that has to do, that's going to be the exact same now for established patients as well as for new patients, whereas in the old system, it wasn't always that way. Okay, so now as we make our way through the coding card, let's first talk about the problem column. So this is the number and complexity of problems addressed. And the way to really think about this column is that it is the assessment. So it's the assessment for the diagnoses that we are having that day. It must be diagnoses that you're addressing that day. You have to have evaluated them as well as come up with a management plan for them that day. If the patient has other diagnoses that you are not dealing with that day, they are not to be included in your determination for the code on that particular visit. 2 other terms that I think we need to understand well before we dive too far into this is morbidity and mortality. Morbidity really means a state of illness or functional impairment that's expected to be of substantial duration, during which function is limited, quality of life is impaired, or there's organ damage that may not be transient despite treatment. So I think if we stop and think about that definition, there's a lot of ways in eye care in which that can be relevant for us, because anything that is substantial duration, which, we can all look at that definition in our own eyes, but typically that's going to be around 6 months or more. Function is limited. So think about someone who's had a concussion or someone who's had a stroke, they have a cranial nerve 6 palsy. Certainly their function is limited and their quality of life is going to be impaired. And then now think about organ damage. So that means that there's going to be permanent damage to the eye itself. Maybe the patient has a corneal ulcer and it's central and we know that they're going to have scarring. They're certainly going to have organ damage that may not be transient, so it might not go away, despite the fact that we could treat it. So think about how, the patient's morbidity could be affected in so many ways in all the different things that we deal with. And then mortality means likelihood of death, which fortunately for us in eye care, we don't deal with that very often, but there are certainly some scenarios where that comes up. But it's much more common that we're going to be thinking about how the patient's morbidity is affected compared to mortality. So first, what I want to do is go through and describe what all the different definitions are within the problem column. So the first one is self-limited or minor problem. This really means a problem that is going to run a very defined and prescribed course. We know what's going to happen. It's very predictable. It's transient, meaning that it's going to go away, and it's not going to alter their permanent health status. And it's going to run its course whether or not you intervene. And so the things that I think about when I think about things that are not going to cause a problem, that I know exactly what they're going to do, and it doesn't really matter if I do anything or not, is a subconcheme, a really mild viral conjunctivitis, maybe a really mild hordeolum, but it's going to depend on the hordeolum, and then maybe mild allergic conjunctivitis, again, depending on the severity of the allergic conjunctivitis. So you can think about when you're in your record then, when you're documenting, you have to make it very clear where the patient's status lies. Subconcheme, I think we can all agree that that's pretty much always going to be self-limited, but some of these other ones, it's going to depend on how you define the severity of the problem in your patient's record as to whether or not it'd be considered to be self-limited or a minor problem. The next one is an acute uncomplicated illness or injury. There is certainly some overlap here between self-limited, and it really is all going to come down to the resolution course. Is the resolution course predictable, and is it well-defined, or is it more muddy? If it's more muddy, then it's probably an acute uncomplicated illness and not a self-limited or minor problem. So these are all going to be short-term issues though, right? Because it's an acute problem. A very low risk of morbidity. So that means low risk of having functional impairment and low risk of it causing organ damage. And there's almost little to no risk of mortality with treatment. We expect the patient to fully recover. It could be self-limited, but again, doesn't have a very defined resolution course. So these are now those hordeolums or those conjunctivitises that are just a little bit more complicated, where we probably should intervene, because we don't know exactly what's going to happen. It's not super, super predictable. So we need to make that clear in our chart that we are intervening or that we don't think this one is just a simple self-limited problem. The next one now is acute illness with systemic symptoms. And so an illness with systemic symptoms means either a general or a single system. There's a high risk of morbidity without treatment, so we expect there to be problems. And so what we're looking for here is associated side effects. And this comes up a lot. We just have to remember to document it. So a good example is the patient comes in and they have EKC and they also have lymphadenopathy, or maybe they have an upper respiratory illness. Make sure you document that they have coughing and sneezing, or they had a recent upper respiratory infection in your chart. And if you do, then you've now got an acute illness with systemic symptoms. Another example is an acute cranial nerve palsy. If they also have other signs associated that are systemic, like lightheadedness, maybe they're nauseous, maybe they're vomiting. If there's something else that's going on, make sure you put that in your record. Another one is a severe corneal abrasion. If they have associated nausea, then that's an example of a systemic symptom. And ocular migraine is a pretty easy one, right? Because there's likely going to be headache or fatigue. And as long as we put that on a record, we have an acute problem with a systemic symptom. The next one now is an acute complicated injury. This one bothers me because it doesn't say acute complicated injury or illness like it does in the acute uncomplicated injury or illness. So it makes it challenging because those patients that come in that have an acute complicated illness, if they don't have a systemic symptom, it makes it really challenging to decide where we want to put them. Do we want to just bump it down and put them in acute uncomplicated illness, or do we want to keep them up here in the moderate level? And that's a difficult decision to make. And I think you just have to make sure that your documentation supports whatever you choose to do. But an acute complicated injury means that there's more than one body system involved. So it's more than just the injury to the specific organ that you're dealing with. So a good example would be maybe someone that comes in that has an orbital fore fracture. Maybe they have a uveitis and they also have a fore fracture and a nasal fracture. You know, that's a pretty extensive injury that's involving much more than just the eye itself. Whereas if the patient came in and they simply just had a uveitis and there was nothing going on with the orbit or nothing going on with the nasal cavity, then that would just be, you know, an acute uncomplicated illness or injury most likely. Now let's talk about a stable chronic illness. So a stable chronic illness means it's supposed to last at least a year or until the patient's death. So if you're wondering what chronic means at least 1 year. It also means that a change in stage or severity doesn't change whether, a change in severity or stage doesn't change whether or not it's chronic or not. Chronic really has to do with the length of time. Another key to this one being stable in the world of E&M coding now means that the treatment goal has been met. It doesn't necessarily mean if it hasn't changed since the last time you saw it. And the giveaway here in your chart is going to be what your treatment decision is. So if your treatment decision is that you're going to keep the patient on the exact same treatment that they were on the last time you saw them, then if you go and look at that record, it looks pretty obvious that the patient's problem is stable. Whereas even if you have the exact same condition, but you go ahead and change treatment, then that is flagging the auditor that you must not be satisfied with the patient's treatment. They have not met your goal. So therefore, you're changing something about it. And then the other is that because we are in the moderate category here, its risk of morbidity is significant without treatment in these stable chronic illnesses. I think the easiest one example to think of is glaucoma. So glaucoma, if you've met your IOP target and you don't change medications, then that's clearly a stable chronic illness. But if you have a patient with glaucoma and they have been at the same IOP for the last couple of visits, but you're unhappy at that because they're not meeting their target goal, and you decide to make some kind of move, either you add another medication or maybe you refer for a surgery, then it's obvious that the patient's condition is not stable because they have not met their target goal. So therefore, you would be able to count this as a stable chronic illness. Another example that comes up for me quite often is amblyopia. So if the patient's goal is to meet 20/25 or better vision and that has not been met, the patient is not at a stable state. Therefore, I can count it as a stable chronic illness. So one thing I've started doing in my records really since the early part of 2021 now is adding in there what my goal is. We're good about doing that in glaucoma. We tend to set a target IOP in our chart, but we don't tend to do that as much for other chronic states. So highly consider doing that. Now with dry eye diagnostic tools, it's easier to set target goals. You can have a goal of what you want the osmolarity to be, or perhaps what you want the lipid layer to be if you have a lipid view. There's ways that we can set goals, or potentially it's a goal based off of symptoms. In amblyopia and strabismus, we can set it based on frequency or set it based on the visual acuity. And then make sure it's an achievable goal. If you have a patient, I think about amblyopia. If I have a patient that has really long-standing amblyopia in their teenage years, it's probably unrealistic for me to set their goal at 20/20 with complete stereopsis. So I need to have a reasonable goal that I'm trying to meet. And then remember that your chart is going to give yourself away. So if your chart shows that you have not changed treatment, then likely you have a stable problem. If your chart shows that you changed treatment, then clearly you were not satisfied with where the patient was. So now let's look at chronic illness with exacerbation, progression, or side effects of treatment. So these are all the ones where it's the opposite, right? You're making that move, so therefore you're showing that the illness is worsening, it's not well controlled, or it's progressing. The condition often requires additional care or treatment of side effects are needed. And there's so many examples here, right? We've got worsening cataracts that you're changing prescription on, or perhaps you're sending for surgery. You've got worsening diabetic retinopathy, so you're going to increase the time frame in which you're going to see the patient back. Worsening dry eye, so you're adding more treatment. And then also think about side effects of treatment. So I think about, in my world, I put a child on atropine for amblyopia. There's certainly a lot of side effects to that, and one of the side effects can be near blur, and that warrants me to prescribe near reading glasses for the odd child. So that would be an example of where I require additional care because of the treatment or because of the side effects of the treatment that I had to do. So that would be an example of where I would meet that second aspect of this one. And then now let's think about chronic illness with severe exacerbation, progression, or side effects of treatment. This one really all comes down to the risk of morbidity to the patient. There has to be significant risk of morbidity. Oftentimes the patient might require hospitalization. Some examples here, these are going to be the big bad ones, right? So it's neovascular glaucoma, maybe a CNVM, because there's significant risk for long-term vision impairment, and then proliferative diabetic retinopathy. You can kind of think about the continuation of what can go wrong in a condition, where if you're trying to label it as stable versus progressive versus severe, think about how bad that condition can get and where the line is crossed as to what the visual effects are going to be. And once the patient has long-term or really a significant risk for having long-term organ damage where their quality of life is going to be impaired, that's when I'm starting to think about this one here, which is that chronic illness with severe exacerbation. Now let's go back to acute problems. So acute or chronic illness or injury that poses a threat to life or bodily function. So again, this is our big bad ones. These are short-term, very severe visual threats. These are the things that we are nervous, right? If you're sweating a little bit during the eye exam because you're nervous about what you have on your hands, then you might have something in this category. So these are where vision has a really strong risk of being impaired. And remember that vision is really important for bodily function, and that morbidity definition includes threat to bodily function. So these are things where risk of vision is high. So retinal detachment, and AION, orbital cellulitis, retinoblastoma, all these big bad ones that we are likely getting out of our office pretty promptly. Okay, so now let's think about how we're going to define the problem overall. So remember that it's all number and complexity of the problems addressed during the encounter. There's 4 levels, right? So straightforward is usually going to be a self-limited condition. Low is going to be one of those stable, uncomplicated issues that we're not making any changes on. Moderate is where there's either multiple stable conditions or you are making a move or making a change in treatment for a chronic issue. And then high is there's something bad going on, right? These are the ones that hopefully don't happen every day. For those of you that are in, certain clinical scenarios, maybe you do deal with them on a daily basis, but those are those ones where vision is really at a strong risk. And remember that it must be a problem that you're dealing with on that particular day. It can't be something that's historically a part of the problem. So an example is patient might have diabetes and maybe they have COPD and hypertension, but diabetes might be the only one that's relevant as to why you're dilating the patient that day. And if that's the case, it's only one problem that you're addressing, not multiple problems. Okay, so we've made our way here through the presenting problems there. So now let's think about how we combine it all together and use those definitions to determine what the level is going to be. So for minimal level here, which is straightforward, it's going to be just one self-limiting or minor problem. So an example would be eye irritation after the patient thinks there's a contact lens in the eye. And of course there isn't, right? Because there almost never is a contact lens in the eye when the patient thinks there's a contact lens in the eye. Or they have maybe one very mild conjunctivitis or a subconchine. Those are going to be your self-limiting or minor problems, which is going to be a minimal level, which will be a level 2. Level 3 now is where you're dealing with multiple self-limiting problems, or maybe you have one stable chronic problem or one acute uncomplicated issue. Our moderate issues now are where you have multiple stable problems, or you have one or more chronic illness that has some progression, so you have to make a change to treatment. You have an undiagnosed new problem with uncertain prognosis. This one is really tricky one. I've been to a couple of coding seminars where they really try and stretch the use of this statement right here. The example that I can think of, and because perhaps some of you guys have run into this, is that patient comes in and they have a red eye, and you examine the red eye, and while you're moving through the exam, you don't know what it is, right? So when it presented to you, it was an undiagnosed new problem. But then you went through the exam and determined what it was, and you figured out, let's just say it was bacterial conjunctivitis. So you go ahead and diagnose the patient with bacterial conjunctivitis and come up with a treatment plan. I've been to a few coding seminars where they are labeling that as an undiagnosed new problem with uncertain prognosis. But since you've made the diagnosis in that visit, that's really not the case. It's no longer undiagnosed, and maybe it has uncertain prognosis depending on what you're dealing with. But in the case of the bacterial conjunctivitis, it is now an acute uncomplicated illness or injury. So I think the best example where we can really use this one in eye care is, again, glaucoma. So a patient comes in and they're here for another medical reason. And while you're in that exam for a medical reason, you realize that you think they have glaucoma, but you're not really sure. So you need to have the patient to come back to do some testing to figure out what the true diagnosis is. Another example is someone that comes in and has a lid lesion, but you don't know what the lid lesion is. And so you refer the patient for biopsy. So you've got an undiagnosed new problem that has uncertain prognosis because you really don't know what you're dealing with. And then we already talked about these bottom two here, this acute complicated illness or acute complicated injury, and acute illness with systemic symptoms that also lead to moderate level. And then your high level, again, are going to be those big, bad, scary ones. And we've got a chronic flavor as well as an acute flavor that can really be the impedance for us to choose the high level. So now let's transition into data. So this is the one that I mentioned that for us in eye care, we just don't tend to use as often. And I think you'll understand why as we move through this. The purpose of this, though, is to give credit for clinically important activities, such as ordering tests and communicating with other members of the healthcare team. Because this is really an important thing, and we should be given credit for that, right? We should be given credit for taking the extra step to do more diagnostic testing. And we should certainly be giving credit for doing communication with other members of the healthcare team. And so that's really where the whole data idea has come from. And it's broken down into 3 different categories. So the first category is tests, documents, orders, and independent historian. And you can count each unique test, order, or document to meet a maximum threshold level. The second category is independent interpretation of tests. And then the third category is discussion of management or test interpretation with an external physician or other qualified healthcare provider. So let's first talk about this category number 1, which is tests, documents, and orders. So this means that you are reviewing prior external notes from a unique source, reviewing the results of a test, or ordering a test. And the important thing to remember on this one, especially for these notes, is that it's each unique source. And so if you are having a patient that was referred into you from a provider and they send you their last 6 exam notes, that's still only one unique source. It's not 6 separate notes that you're reviewing. Whereas if the patient is being referred to you, but then you also go and pull records from different healthcare providers, maybe you need their last optometry visit, maybe you want their last primary care doctor visit. Now you have multiple sources that you're reviewing, and you can count as many sources as you obtained. And then reviewing the results of each unique test, that's going to be tied to the CPT code. However many CPT codes that you're reviewing, though there are some that are in bundles. For example, a CBC and other lab tests are often considered a bundle of tests. And then ordering is the same thing. Okay, so review of external notes. We already talked about this a little bit. So it's going to be external, each unique source, and you can only count those sources once per visit, and you can't count the same notes twice. So if you already reviewed the notes and counted them on a previous visit, you cannot count the same notes. But if you obtain more visit notes from that same source on a follow-up visit, now you can count that source again. So example is patient is sent to me for amblyopia visits or amblyopia management, and I review the last 3 visit notes from the referring doctor. I now can count one unique source. If then 6 months goes by and perhaps they see this other doctor here in the meantime, they come back and see me again, and I want to get that other note that I don't have yet, now I can count that source again because I've reviewed more notes from them on separate days on a separate visit. Tests now for reviewing and ordering tests. Those are any imaging, lab, psychometric, or physiological data tests. A clinical laboratory panel, as I mentioned, is considered to be a single test. So you cannot count each individual CPT code that is on that panel. And the differentiation between single or multiple unique tests can be found in the CPT code set. So you can look this up if you're curious as to which tests you're ordering. And tests are going to include lab tests, diagnostic tests, or anything in the medicine section of 90,000s. And so we order tests pretty frequently from all 3 of these categories, especially this 90,000 category. But there's unfortunately several rules in place that don't allow us to use this bullet point here quite as often as we may like. And so rules for the tests. So if you are going to be paid for the test, you can't count the order or review. And this is where in eye care, we really get pigeonholed into not being able to use this data section as often because we get paid separately for the majority of tests that we order. For example, Humphrey Visual Fields, OCTs, gonio, PACS, all of those things we are billing separately and being reimbursed for separately. So we can't count the order or the review if the test will be performed by ourselves and get paid to us. We can only count that if it's going to be done by a separate facility and paid to that separate facility. You also can't count both the order and the review. So I think I'll put myself in a primary, well, I guess I'll put myself in my own shoes. Let's say I don't have an OCT in my office. And so I order an OCT and I send them down the road to my friendly optometry colleague and have them do the OCT at their office. And that practice runs the OCT and bills the OCT and then sends the patient back to me with the data. I cannot count both the order and the review on separate days. I can only count one or the other. I can't count both, but I can count that test because I was not paid for it. It was done at a separate facility. So for me, really, and for all of us in eye care, really the time that we can use this data column in the testing particularly is when we're ordering lab tests and ordering radiological tests, because those are really where we're sending people to the outside world to get testing done. So that's doing lab tests or doing MRI and CT. But remember, you can't count both the order and the review. You also cannot count tests that were done by another colleague in your practice. And that's based on the practice's NPI number. So there may be some strategies that you can work around that if you are an OD, MD practice, or if there's different NPIs underneath the same roof. But in general, you cannot count a test that was done by a colleague either, because that revenue is still coming to your practice. So now let's think about independent historian. And for me in pediatrics, comes up for me all the time. So an independent historian is an individual who provides history in addition to the history that's provided by the patient, who is not able to provide a complete history or reliable history. And it's deemed by you as a clinician that confirmatory history is necessary. So examples are if the patient is a minor, you need to obtain history from the parent or their guardian. If the patient is impaired in some way, perhaps they have intellectual disabilities, or perhaps they have cognitive impairment through dementia, and you need to obtain history through someone else other than the patient. And the clinician has to obtain the history because the patient can't provide a complete and reliable history. So you need to document in your record as to why you're obtaining that history. If the patient is a child, it's obvious because you do need to obtain history from them because the child is 10 and obviously can't give a reliable history. But if the patient is an older patient and you're obtaining history from someone else, it needs to be clear as to why you determined it necessary to obtain history from someone other than just the patient. Okay, so now let's move on to category 2. which is looking at independent testing not reported that are not reported separately. So these are tests that don't customarily require that you interpret them. It can be a test that you or a colleague in your practice previously interpreted and were paid for, or cannot be, sorry, it cannot be a test that, just like in the previous section. I think good examples would be one, if you have a new patient coming to you and they have previously been seen by another provider or another practice for glaucoma care, and they come to you with their file folder full of stuff, or you obtain it from that previous doctor, and there's OCTs and there's fields in there. And you review that raw data and you provide a specific interpretation for it and document your interpretation. So now that you're reviewing a test that you were not personally paid for, you can count that independent interpretation of that test. And you'd want to interpret it the same way that you would typically interpret an OCT or a Humphrey visual field. Another example is that if you order neurological imaging, such as an MRI, most commonly what happens is that you just get sent the report. But if you decide that you really want to go and look at the actual images, and you go and look at the images and then document exactly what you interpret and write your own interpretation report, you can also now count this independent interpretation of the test. But it doesn't just simply count for you to say, I looked at the images and move on. You have to write down exactly what your interpretation was of those images. And then now let's look at category 3, which is discussion of management or test interpretation with an external physician. So this is someone that is not in the same group practice as you, or is a different specialty or subspecialty. So there is a bit of a blurry line here between optometry and ophthalmology if you're working in a practice that contains both specialties, but it includes licensed professionals that are practicing independently. And it may also be a facility or organizational provider, such as a hospital, a nursing facility, or a home healthcare agency. And that's what it means by external physician or other qualified healthcare provider. So it doesn't have to just be a doctor. It can be also the nursing facility or home healthcare agency if that is applicable. A big caveat on this one, and this gets me all the time in my practice, is that the discussion must happen on the day of service. And it has to be a two-way conversation. So it can't just be that you called and left a voicemail for another doctor, or perhaps you called, or perhaps you wrote an email, but the person did not respond to you. So it has to be a two-way conversation. The method of communication doesn't matter. It can be email, phone, video, in-person conversation, whatever works. And you have to document the discussion. So you have to write down that you did it, who you talked to, and what your method of communication was. But it doesn't matter, and then it has to be done on the day of service. And so this gets me a lot. I work with concussion patients a fair amount, and I'm working with a hospital-based system. And it's really difficult for me to have these conversations on the day of service. So unfortunately, I usually end up having these conversations the day after with the provider, and then I cannot count it towards data, which is a bit of a bummer, but it is what it is. Okay, so now let's think about how we define the levels of data. So we've gone through how we can obtain data. Now, how do we define the levels? So straightforward, which would be a level 2, means minimal or none. And unfortunately for us in optometry, that's where we're going to land most of the time, is minimal or none. Low means that you did 2 of the following things, which would be a level 3, which would be reviewing a prior external note from a unique source, reviewing the results of a test, or ordering a test. And you have to do 2 of those things, or assessment requiring independent historian. So what this means for all of us that see kids is that you're always hitting a level 3 in the data column, at least, because of that assessment requiring independent historian. Because you don't have to do 2 things in conjunction with that. You just have to have an independent historian. And then now let's look at moderate. So moderate means you have to do 3 of those things previously, or you have to do one of the following, either 3 of those previous ones that we talked about, an interpretation of a test from an outside source, or a discussion of management or test interpretation with an external healthcare provider. And then to be high, you have to hit 2 of those categories. So it's awfully difficult for us in eye care. It's hard for me to even think of a scenario in which we would hit high on the data column. You'd have to be doing a lot of outside testing and a lot of communication with outside providers to really hit the high category. Okay, so now let's talk about risk. So this is the plan, really. So we've talked about the assessment. Now we're going to talk about the plan. So as you can tell, really, our E&M coding has really shifted a lot. It used to be heavily focused on our history and our exam elements, And now it's heavily focused on our assessment and plan, which is probably the way it should be, right? So now when we're talking about risk, we're talking about the plan. So this is risk of complications and or morbidity or mortality based on the decisions that are made at the visit associated with the patient's problem or the diagnostic or procedures or treatment. So it's not necessarily just what your treatment is, it also could be the risk of the diagnostic procedure. This includes the possible management options selected, those considered, but the patient decides not to move forward with after you have a conversation with the patient about what their options are. So it's not just what the patient decides to do, it's also the risk of those that they choose not to do. And really the way that you want to think about this is it's the risk of hurt or harm. What could happen if you intervene? What risks does the patient carry if you intervene? And what adverse events might occur? And this is categorized in 4 ways, just as our other 2 categories, just as our problem and data are, and that's minimal, low, moderate, or high. So let's first look at minimal. So these are some good examples. And one thing I will say as I move through this risk section is that risk is tricky. I think it's the hardest part of these 3 categories to utilize what the AMA has given us and come up with ways that we can translate that into what we do in eye care. Because again, remember, we're a small piece of the healthcare puzzle, and a lot of the guidance that's given by the AMA is not geared directly to eye care. So we have to look at the guidance that the AMA gives us and extrapolate it to what we do. And so some of these guidelines that I'm going to give you as you move through here are based on other coding experts, myself, folks here at Indiana University, and some third-party consulting groups as well, to come up with really the best way to interpret what the AMA is telling us in our day-to-day life as optometrists. So in minimal risk, we are looking at patient really doesn't need to do much, right? It's rest, superficial bandage, and they don't need to do any follow-up care. So really the way to think about it is that your treatment here is really causing no harm to the patient. And this makes sense, right? Because these are likely scenarios in which the patient has a problem that has a well-defined course and we know exactly what's going to happen. But do keep in mind that you might have a problem that is really high because the patient might have something significant going on, but there might not be treatment available for them. And so their risk might be low, and that might drag your appointment down to a lower level than what you really feel like it should be. And that comes up a lot. And when that happens, highly consider using an eye code. I think a good example is the diabetic patient. You know, if you're just observing moderate retinopathy, there's really not much risk to observation, right? So you're not going to hit a very high EM level, even though we know that the patient has moderate level of disease. So highly consider using an highly consider using an eye code instead of an EM code in those scenarios where the risk is really does not carry as much weight as the problem does. So now let's look at low risk. These are typically going to be self-care or simple home treatments. So anything that you prescribe that the patient can do at home on their own that doesn't require your intervention in the office is going to be considered low risk. It's also going to be a minor surgery or procedure without identified risk factors. And I'll talk about surgical stuff here in a little bit more detail shortly. Any over-the-counter medication for amblyopia management, it's occlusion therapy. And then another way that you can think about these levels of risk is how frequently you want to see the patient back. So observation. So if you want to observe the patient on a yearly basis for whatever it is they have going on, you can probably extrapolate that to a low risk. Do keep in mind that the AMA does not include that in their guidelines. That is just the consensus of several coding experts in eye care. So if you don't feel comfortable utilizing the observation timelines, that's completely fine. That's your decision. But this is a reasonable approach, is that if the patient has relatively minor disease, so you're seeing them back on a yearly basis, maybe they have mild dry eye or they have mild AMD, and you need to see them back on a yearly basis, you can probably consider that as low risk. Some examples now of things that we commonly prescribe for patients. So any at-home based remedy, right? So that's going to be Bruder mask, lid hygiene, Amsler grid at home, doing home-based vision therapy, so not specifically in your office, doing patching for amblyopia, and then any type of over-the-counter treatments. That could be artificial tears, that could be lid scrubs, that can be Lumify, any over-the-counter drugs like Pataday. Glasses prescriptions are also considered to be low risk, and then that yearly observation that I mentioned. And then now let's think about moderate risk. So moderate risk is going to be prescription drug management, minor surgery with identified risk factors, elective major surgery or procedure without identified risk factors, or if the patient's diagnosis or treatment is limited by the social determinants of health. And then the other way we can think about that is that if the patient has follow-up care that needs to happen sooner than a year. So, and probably the best way to think about that would be patient needs to come in some interval of months. So whether that be 3 months, 6 months, 9 months, something shorter than a year, but not tomorrow, like not one day follow-up. But if the patient needs to be coming in more frequently than a year for whatever it is that you're observing them for, or whatever it is you're treating them for, then, and that is because you think you might need to change treatment, then the patient could be considered to have moderate risk. And probably the best way to kind of describe that is think about the patient that has strabismus or amblyopia. And so you need to see the patient back in 6 months because you think you might change their spectacle prescription. That is, and so what you're basically saying is that your spectacle prescription is only good for 6 months. And so they need to come back because you need to reevaluate the spectacle prescription and prescribe it again. Another example is glaucoma. You prescribe them medications and you want them to come back in 6 months, and that prescription is only good for 6 months. So you need to have them come back and have a renewal of that prescription. So that's going to help you get to that moderate risk if you're seeing them more frequently than just a year. Another way to think about it is that when the intervention that you're prescribing for the patient requires your time in the office. So that low risk was patient had to do things on their own at home. Now, moderate risk is patient needs to spend time in the office working with you. Ways that this can come up, of course, is in-office vision therapy or some dry eye treatments like meibomian gland expression, maybe a LipiFlow or a MibaFlow, something in the office that needs to be done. Atropine therapy for amblyopia, because it involves a medication that can be absorbed systemically and carries a risk of side effects, that is considered to be moderate risk, while occlusion is just considered to be low risk. And then any prescription medication, because there's that risk of systemic absorption. And then, as I mentioned before, care is limited by the social determinants of health, will also carry them to moderate. So here is a list of the social determinants of health. And really what your job is when you're utilizing this as moderate risk is that you have to document what that limitation is and how it impacts their care. I think examples that we deal with frequently is that patient can't afford the treatment that they need. So you, in your plan, then you're going to write, like, I recommend this treatment, but due to cost, patient can't consider, and et cetera. This is what we're going to do instead. So you're clearly showing that there is a reason for why the patient's not going through with the treatment that you're prescribing. Another example is patient lives in a nursing home, which makes it really complicated for getting their treatment on a daily basis. Or perhaps they live far away and it limits their ability to come to your clinic. So those are two other ways that the social determinants of health seem to come up pretty frequently. And I think about it a lot for transportation issues. You know, you might really want to see the patient back more frequently, but because they have such transportation issues, you really can't. So make sure that in your record, you're writing down what you really want to do, and why you're doing what you're doing is because you're limited by transportation issues, or you're limited by the care that they're getting at home. They don't have a caretaker that can, do what you need them to do. And so as long as you're making it clear in your record as to how they're limited and how that impacts your care, then you will hit the social determinants of health, which would be considered moderate risk. And then now let's look at high risk. So high risk is elective major surgery with identified risk factors, emergency major surgery, hospitalization. If the patient has very poor prognosis, so care is de-escalated. And then here's where that interval comes in. So patient needs to be seen within hours or days. So I think about patient with corneal ulcer that you want to see back the next day because you are concerned that this thing is going to go quite south, or you need to see them back because you need to change their treatment management, right? Because you know that you're waiting for the epithelial defect to shrink in size, and then you're going to decrease the amount of times that they're on their eye drops. So there's a reason for why you're seeing them back, and that is to alter their treatment. And if that's the case, then you can probably argue high risk rather than just considering it to be moderate risk. Again, remember, the AMA does not discuss the follow-up time care needed. That is just the general consensus from some coding experts. So if that part makes you nervous, there's always the safe road to go, which is to just think about what the AMA has printed for us on their guidelines there. Okay, So now things to think about, right? So we've talked about this. The interval for care can potentially be a useful way to think about risk. If it's yearly, it's probably low risk. If you're seeing them more frequently than yearly, then probably moderate risk. If you're seeing them like the next day because this thing's bad, then it's probably high risk. And then also think about the spectrum of care for a patient and for a particular diagnosis. So if I think about dry eye, I can go anywhere from observation all the way up to a Procara or a tersorrhaphy. And there's a lot in the middle of that. So kind of think about where your treatment that you're choosing kind of lies in the spectrum of what's available for that condition. And so I would kind of think about observation as being minimal risk in this scenario. Artificial tears and Bruder mass are kind of my home remedies. There's really very little risk to them. What kind of damage can a patient do or have done to them with an artificial tear or Bruder mass? That's low risk. Whereas now my Restasis is a prescription medication, so we have more risk. Lipitor requires in-office time, so it's moderate risk. And then of course, Procara and Torsorrhaphy carry a lot more risk, so I'd be maybe more apt to think of them closer to the higher scale of risk, depending on how much you want to kind of push those ones to the next limit. And then also surgery. So I mentioned I would talk about surgery, so here we go. So the biggest difference from the previous guidelines is that minor and major surgeries are no longer tied to the global period like it was in the old system. It really boils down to the surgeon's judgment. And there's a reason why that happened. And that happened because sometimes there was surgical procedures that have significant complications or procedural risks that didn't have a global period. The examples that you'll see in the AMA is a heart catheter or an endoscopy. Those things don't have global periods, but they do carry significant risk. So that's why this system was changed. But it means that there's a lot more ambiguity to it because it's really the surgeon's judgment. So ways that you can kind of decide where you think you want to put the surgical risk is think about where the procedure is done and think about the type of anesthesia that's done. If it's a surgical procedure that's done in an operating room, it's probably more likely to be a major surgery. Whereas if it's a procedure that's done in an outpatient clinic, the patient is under local anesthesia only, it's probably a minor procedure. So it just kind of depends. Think about those things that'll help you. Also think about the follow-up care and think about what the post-op care needs to be and when the patient has to be seen next. So if I think about intravitreal injection, there's really no post-op care there, right? And there's not any systemic anesthesia. And there is obviously a significant risk for endophthalmitis, and endophthalmitis is obviously quite bad if it happens, but that doesn't mean that there's a high risk to the procedure because there's no anesthesia involved. The patient doesn't need follow-up care. And so this is going to be considered a minor procedure. Again, capsulotomy now might be a slightly more complicated because we do need to have a follow-up care or follow-up time frame for them. And so maybe we consider that one more moderate. And then cataract surgery, we do need to have a follow-up with them within a day. And so that might be considered more of a higher risk procedure. I think most people would agree that cataract surgery is considered a major procedure. And that's kind of why, is that there is a lot more to the follow-up care that comes from the cataract surgery. Even though really the risk for vision loss can potentially be somewhat similar to the intravitreal injection in the case of endophthalmitis at least. And then the other piece on the surgical part is think about identified risk factors. And so what that means is it's unique problems to the patient. It doesn't mean that the procedure has a risk because every procedure has a risk, right? This means that there's something unique about that patient that makes them more likely to have problems in the procedure. So think about the patient who is monocular and is undergoing cataract surgery. That is a higher risk surgery for that patient because they are monocular, because they only have one chance at having good vision with this cataract surgery. And then think about cataract surgery in a patient that has a collagen disorder, like someone like Stickler syndrome, that is not a straightforward cataract surgery anymore. Someone that's had a traumatic event and now they are having cataract surgery, or perhaps an intravitreal injection in someone with really severe dementia who can't fixate very well. That might make that cataract or that procedure more challenging. Another might be cataract surgery in someone who has significant fuchs, because that's certainly going to make the outcome of cataract surgery a lot more dicey. And then here is a guideline for you. This is just a guideline. So again, remember, it comes down to surgeon judgment. So this is just a guideline that's been put together by several coding people as to where these things fall. but you can kind of get a feel for it, right? So if you look at the major procedures, these are things that are requiring pretty extensive procedures. In the case of strab surgery, you're under general anesthesia. Retinal detachment repair, again, general anesthesia. Whereas all these minor ones are typically things that are going to be done in the office with very, with not very much anesthesia, and are going to be seen in a relatively short follow-up time frame as well. Okay, so some other tips for charting when we're thinking about risk is also don't forget to include risks, benefits, and alternatives in your treatment plan, because it's not just about the treatment you choose, it's also about the treatments that the patient elects not to do. So make sure you're including all of the options that you laid out for the patient. That's really the best plan. The best plan says discuss options of X, Y, and Z. Patient chooses X for X reason. And then therefore you've got everything that you need that an auditor could possibly want. So I've given you a couple of examples here that you can go through and read if you like, but really the whole point of it is just to show what the conversation was and what the whole picture may be and what other treatment options the patient may have. Okay, so with our last little section here, let's go through and look at some case examples of some E&M coding. So here first is red eye number 1. So we've got a 25-year-old established female, and she's coming in complaining of itchy, red, watery eyes that started about a week ago. In the exam, we find that she has mild conjunctival edema and injection. She has no corneal involvement, and her acuities are normal. So the diagnosis here is allergic conjunctivitis, and the plan is to recommend Pataday once a day in both eyes. So let's go through and think about where we would land on problem, data, and risk. So problem. I think we will have a little bit of debate here kind of right out of the gate. So I think the problem could be defined as either self-limited or minor, or it could be considered an acute uncomplicated illness. And I think somewhat your treatment is the giveaway, because in this scenario, we're telling the patient to choose an over-the-counter treatment regimen. We're not saying, oh, just wait it out, or oh, just use cold compresses. So you probably have enough justification here to choose an acute uncomplicated illness or injury. But there might be scenarios in which the allergic conjunctivitis would be popped down to a minimal. One thing to realize, because we clearly said in the assessment or in the examination elements here that there's no corneal involvement and they have normal visual acuity, it'd be really difficult to justify this as being moderate in terms of the problem, because there's really very limited effect going on with the eye. And likely if you did nothing, this is probably going to go away with very little harm. So I think this one is going to be best case scenario would be a low. And then for data, we're not going to have any, right? Because we didn't have any conversations with outside healthcare providers. We didn't order or review any extra testing. And in this case, it's a 25-year-old female who is very with it and doesn't need to have an independent historian to assist them. So we don't have any data column here. And then our risk level is going to be low. And this is an easy one for us to pick, because we have an over-the-counter medication. And over-the-counter medications are going to be low. So here we have low, minimal, and low. We're going to pick the highest 2 out of 3, which is going to take us here to a level 3. And for some of you, you might be more apt to choose this level 2 because you think it's a self-limited problem, and that's fine. That's your decision if you think that's what's best. It's going to depend, of course, on what the patient's presentation is going to be like. And then can we meet a 92,000 code? So don't forget about these, right? So remember, for this 92012, we need to have a new problem that is complicated by a new management problem. And we also need to have looked at the anterior segment. And so we have met this 92012. So now you would just want to look at your reimbursement rates and determine which is going to be better for you to bill. And it might be dependent on whether or not you choose the level 2 or the level 3, because this 92012 is probably pretty easily going to beat out the level 2, but it might not beat out the level 3 in terms of reimbursement. Okay, so now let's look at red eye number 2. So here we have a 10-year-old established male, and this patient is complaining of a red right eye, sticky matter on the lashes when waking up, and a mild foreign body sensation. Again, normal visual acuity, no corneal staining or involvement, and there's only a conjunctivitis present. So here we have a bacterial conjunctivitis that is labeled mild to moderate, and it's new. And we prescribe polytrim, so a topical antibiotic, and say return to clinic as soon as possible if we have increased redness, pain, or decrease in vision. Okay, so where do we stand? So for our problem, it's kind of a similar discussion to last time, except that now I think it's obvious that we don't have a defined course. And intervention really is going to be needed here. So it's not going to be a self-limited or minor problem, but it's going to be an acute, uncomplicated illness or injury. It's not an acute, complicated illness because there's no corneal involvement, there's no visual acuity effect, there's no systemic association or systemic symptoms. So I think this one is pretty clear here down at the level 3 level for problem. And then let's go back and look at so we've got a 10-year-old male here, right? So it's pretty likely that we needed to utilize the parent to help us with data. So I actually think that we could change this one here to limited, or because we probably can pick this assessment requiring independent historian. So I think this one actually should say low right here. And then risk, we prescribed a medication that is prescription only. So we are going to be easily here at a moderate risk. And so this one is going to be low, low, and moderate. So we have to pick the highest 2 out of 3, which is going to take us to the level 3. And this one feels like a level 3, right? And we're going to get, I'm sure you guys already have really gotten in the swing of how you want to code these things because the system is so much easier than it used to be. And this one certainly is going to feel like a level 3. And then have we met that 92,000 code? So again, we have to have looked at the anterior segment, done a general medical exam, and then we have to have a new problem complicated by a new management plan. And we certainly do, right? We have new bacterioconjunctivitis complicated with a new treatment plan in the form of polytrim drops. So we certainly could bill also this 92 code if we wanted to instead of this 99 code. Okay, red eye number 3 now is the patient coming in complaining of a red and blurry eye, pain when they first woke up this morning, sticky matter on their lashes again, they have moderate to high tearing, and they're in a lot of pain. And now you can see that things are certainly more complicated than our previous 2 examples. We have 20/70 visual acuity in their affected eye. They have a corneal ulcer with significant corneal edema, and they have a mild anterior chamber reaction. And we diagnosed them with a central corneal ulcer in their right eye. And we talked with them about their high risk of vision loss. They're going to need to be watched really closely. We put some atropine in their eye in the office and then prescribed atropine and prescribed Besavance and told them to come back in a day. And of course, depending on the level, your level of comfort, you might not have decided to bring this patient back, and maybe a culture could have been appropriate too. But regardless, this is what our treatment plan was here for this one. So let's think about our problem, our data, and our level of risk. So problem. For this one, right, these are our bad ones. We certainly have an acute or chronic illness that poses a threat to life or bodily function, because having that central corneal ulcer and there's already visual impairment, they're already at 20/70 visual acuity, we certainly have a high level of problem. Data now, we aren't consulting with an external physician. If we had ordered a test, we would have ordered just one test though through a corneal culture, which wouldn't allow us to meet the moderate level or the low level on testing, because we need to do at least 3 tests in order to meet that. And then we did also prescribe medication, so we've easily met this moderate category. And this is where I mentioned that interval for care. So you could certainly make a judgment and a call that this is considered high risk because the patient needs to come back in a day. And there's plenty of justification for this patient to come back in a day, because you've got a central corneal ulcer that certainly could cause long-term vision problems. So you could consider using the interval for care as the reason for bringing the patient back. But if you want to play it a little bit more safe, you can certainly just use this prescription drug management. But that is going to be the determining factor now here between a level 4 and a level 5, depending on how you decide to label this risk. And then now can we meet one of these intermediate codes? So the first one to think about is this comprehensive eye code. And right away, I can tell you that we're not going to meet that one because we did not do posterior seg. So remember that you have to do posterior seg, EOMs, and a screening visual field in order to meet that 92014 code. So we will not meet that one. But we have absolutely met the 92012 code because we have a new problem with a new plan. But I can tell you it's pretty unlikely that any carrier is going to pay you better for this 92 code than they would this level 4 or level 5. So in this scenario, your better bet is going to be certainly billing the E&M code instead. Okay, so now let's look at a chronic management case. So this is a patient that's coming in for a dry eye and a cataract exam. Their acuity is 20/20, but they have worsening of acuity with their BAT testing. They have some mild corneal staining and a reduced T-BUT, And then the back end of their exam through IOPs, a screening field, they're in their posterior segment is all normal. And so their diagnoses are cataracts and dry eye. Both are stable compared to our visit last time. And the plan is to continue with artificial tears, continue with a Bruder mask, prescribe glasses. They don't need to go for surgery just yet, and then come back again in a year. So in this scenario, we've got 2 stable chronic illnesses. And our giveaway really is our treatment plan, right? Because we didn't change a single thing with treatment. So it's obvious then that these must be meeting our target goal. We must be satisfied with where the cataracts are, and we must be satisfied where the glasses are, or sorry, where the dry eye is, because we didn't change anything with their dry eye regimen. If you felt that these cataracts were actually worsening, then you need to make it pretty obvious in your record, either writing something in the assessment box about the fact that these are worsening because their glare is worsening, or perhaps their acuity is worsening, or perhaps they had a large refractive shift. Yes, you can correct them back down to 20/20, but they had a large refractive shift. So make it obvious in some way in your record if you felt that that was the case. And that would be the difference between it being a stable chronic illness versus one that has exacerbation or progression. So in here, we have 2 or more stable chronic illnesses, which will be a moderate problem. We again don't have any data. And in this case, we've done quite a bit in the low category. So we have over-the-counter medications, we have a home-based treatment with a Bruder mask, and then we also prescribe spectacles. So we have pretty easily met this low risk. And so this is going to get to a level 3. So this is here where I would say, highly consider billing this 92014 instead, because you might get paid better depending on the carrier. And you've certainly met it by doing a comprehensive dry eye and cataract exam. You've done posterior seg, you've likely done a field and likely done EOMs. And then you have done treatment as defined by CPT in many ways because you've prescribed over-the-counter medications, you have that home-based treatment, and you prescribed spectacles and did a refraction. So you've quite easily met this 92014. So certainly consider that. And then glaucoma. So I'm just going to think about glaucoma and not have necessarily specific cases, but let's just think about it in a whole. So the problem in general, if you're meeting the target goal, so if you're happy with the patient's IOP, that's going to be considered a stable chronic illness. So that'll be considered low in the problem. If they are not meeting their treatment goal and you intervene that day, that's going to be a chronic illness with progression or side effects of treatment. Severe, then, of course, is just going to be dependent on the patient's case, right? You're going to have to make that obvious in your exam record that this patient has a severe problem if they've got end-stage glaucoma. And then data is going to be difficult because none of that testing is likely being done by outside providers. You're likely the one that's ordering and getting paid for all of it. So likely there's going to be no data unless you're reviewing outside testing. And then risk. So if you're using a prescription medication, which is pretty common in glaucoma, it's going to be a moderate risk. If you're ordering an SLT, that's going to be considered low risk, interestingly. And that's because an SLT is considered to be a minor procedure. And the patient, unless they have specific risk factors, that would be considered a low risk. Because a surgical procedure, a minor procedure with no identified risk factors is considered low. Whereas if you have patient-specific risk factors, then it's considered moderate. Of course, if you're juggling both prescription medication changes as well as an SLT, then you can get yourself to a moderate risk. But if you're just looking at the SLT, it's considered low risk. If you're ordering a TRAB now, which is a more extensive surgery, that's going to be considered moderate risk. That's a major surgery. And then if the patient has specific risk factors, that might carry them up even higher to the high risk, depending on what you're dealing with. So again, you can kind of think about the spectrum of disease for the problem, and then think about the spectrum of care as to what can be provided for glaucoma patients. And that's going to help you determine what the patient's risk factor is going to be. So now let's think about diabetes. So diabetes, if they don't have retinopathy, so if you're using that E11.9 code, they don't have retinopathy, that's going to be considered low risk. If they have mild or background retinopathy, that's typically, or sorry, not low risk, low problem. If they have mild or background retinopathy, that's also still typically considered low. And then now think about vision impairment. So if they have moderate retinopathy, it's likely moderate. If they have very early DME that's not affecting their vision, that might still be considered low or moderate because there's not currently risk for visual impairment. But once you start getting more significant visual impairment through DME or more moderate DME, then that might bring you up higher. And then, of course, once there is significant risk for visual impairment through either PDR or significant DME, then that's going to be considered high. And it's going to be all about how you document that in your record through your exam findings, through your history, by figuring out what the patient is seeing, and then also through how you document in your assessment box as to where the patient's problem lies. Data, again, you're probably not going to have any. And then risk. If you're just observing, so patient has background retinopathy and you just have them come back in the future for another dilated fundus exam, that's going to be considered minimal to low, because there's really no risk, very little risk at least, to observation. If you now are electing that they go and have anti-VEGF treatment, that's considered to be low, which would be a minor surgery without patient risk factors. If there are specific patient risk factors, and that might bring you up to a moderate risk, depending on what those risk factors are. If they're having laser, you maybe could categorize that as moderate. And then if they're having vitrectomy, that's certainly going to be higher because that's a more extensive surgical procedure. So this is where, for your routine diabetic exams, I'm sure many of you see probably multiple of those in a day, strongly consider using the I-code, which has absolutely changed. Prior to 2021, really the sentiment was to avoid I-codes with diabetes, and that was mostly for meaningful use purposes, but really the landscape has changed. And you should strongly consider now using an I-code for diabetes in which there is no specific intervention. And as in you're not referring to retina and you're not doing anti-VEGF treatment, you're probably better off billing an I-code. And then now for macular degeneration, you're going to find kind of a similar story. So if it's early AMD, it's a low problem. If it's moderate, it's moderate. And then if there's now visual loss or high risk for visual loss because they have a CNVM or they have geographic atrophy, now you're going to be in the moderate to high category of problem. Again, there's probably not going to be any data. And then kind of the same feeling for the risk. If you're observing, that's going to be considered minimal to low risk. If you're recommending over-the-counter vitamin supplementation, that's going to be low. At-home Amsler grid is low. And then anti-VEGF is also typically low because that's a minor procedure without identified risk factors. So it is really difficult in AMD to get to a high level of coding because the treatments for AMD are just not very risky. So again, strongly consider using an I-code when you're dealing with AMD because it's just challenging to get to the level 4 and get to the level 5 with AMD. Even though we might have really severe disease, I think that's the part that we have to remember is that the new system requires to get to a high level, you have to have severe disease and risky treatment. And you might not have both, even though we know that that patient with geographic atrophy is complicated and we should probably get paid well for it because it's a difficult person to deal with, but it doesn't matter because that's not the way the system is built. And then watchful waiting. So ways, again, there's lots of things that we do in optometry that are active surveillance. And that's posterior vitreous attachment. Plaquenil exams are two great examples. Again, probably better off billing an I-code because it's just hard to hit high on that risk category. You might be able to get there on the problem depending on what you're dealing with, but in these two scenarios, you're probably still relatively low on the problem. So strongly consider billing an I-code. Okay, so our optometry cheat sheet. It's funny to spend, in your guys' scenario, you spent 6 hours learning today. I spent 2 hours talking today. And really, it's to boil down to this slide. And that's that the decision that we make is primarily based off of problem and risk, the vast majority of the time. And most of the time, you're probably going to be building a level 3 and 4. And I think if you look at a general practice that is not a referral center, not one in which you're dealing with an absorbent amount of disease, you're probably going to notice that about 60% of your records will be level 3s, maybe about 25% level 4s, about 5% or so level 5s, and then maybe the last 10% will be level 2s. And that's going to shift a little bit, of course, depending on what you're dealing with. And it's going to shift higher toward the level 4 and level 5 if you're dealing with a lot of chronic disease. But in general, you're going to have that nice little bell curve with level 3 certainly at the top. And then when you're making treatment decisions and treatment changes, then that's typically what's going to get you to the level 4, especially when those treatment plans or changes involve prescription medications. So level 2 in general, think of those as ones that really don't require treatment. It's a minor problem. If the patient saw you or didn't see you, they're probably going to end up in the same boat. And those are probably your level 2s. Level 3 is going to be the majority of your encounters. Those are stable problems, things in which you're prescribing over-the-counter remedies for, or self-care, such as an Amsler grid or a Bruger mask. Level 4 is when you've got lots of chronic conditions together, so multiple chronic conditions, progression of a chronic problem, or you're using a prescription medication or a somewhat complicated treatment. Level 5 now is going to be severe condition and there's significant risk to the patient's vision, as well as the patient or the treatment is risky for the patient. And that's really what this new E&M system kind of boils down to when you're trying to make that decision really quickly in your exam room as to what the patient's final level should be. All right, so with that, I thank you, and I thank you for hanging in there through 6 whole hours of coding today. That's awesome.
Thanks, Dr. Connolly. That was awesome. And yeah, I mean, I think that there wasn't really that much overlap from like the different presentations. I mean, of course, there's always going to be a little bit, but I think every speaker has just given us such incredible information.